Coming up on Mayo Clinic Q&A.
So it can, in theory, detect for any cancer. In the development studies and the early validation studies, over 50 types of cancer were detected by this screening test.
A simple blood draw that can find the earliest signs of cancer, particularly those that are hard to identify. It works by finding chemical changes in your genetic code.
What we've learned is that tumors will shed some of their material, be it proteins or nucleic acids, into the bloodstream. And through a simple blood draw, because of technological advances, we're now able to detect tumor-specific material in the blood.
Welcome, everyone, to Mayo Clinic Q&A. I'm Dr. Helena Gazelka. When it comes to cancer, early detection can save lives, and screening tests are used to find cancer before a person even has symptoms. Currently, recommended cancer screening tests only cover a handful of different types of cancer, and we typically only screen for one type of cancer at a time. But now, researchers have developed a novel blood test that could detect up to 50 types of cancer. Joining us to discuss is Dr. Minetta Liu. Dr. Liu is a medical oncologist at Mayo Clinic Cancer Center, and she's the co-director of the Genomics in Action program within the Mayo Clinic Center for Individualized Medicine. Thanks for being here today, Minetta.
Thanks for having me. I'm excited to join you today.
Well, I always love to say on this program that I love to learn something new every day. And I have a feeling today is that day because I'm not familiar with this test and I'm excited to learn more about it.
Mhm.
Before we jump right in, would you tell us a little bit about cancer screening? What do we typically screen for now? I can think of mammograms and breast cancer.
Right. So we currently have 5 screening paradigms for breast cancer, cervical cancer, colorectal cancer, lung cancer, and prostate cancer on a patient-by-patient basis. So those are only 5 out of more than 50 types of cancer that an individual could develop. And many of the cancers that we don't screen for are the ones with high mortality. So we clearly need to do better with our cancer screening methods.
How interesting. So tell us about this latest research using a blood test. Is it called the Gallery test?
Right. The test is marketed as Gallery. In fact, there are multiple multi-cancer early detection blood tests that are in development. This is the product from Grail, and this is the first one out of the gates. There will be others, but this is really paving the way to establishing a new paradigm for cancer screening and early detection.
I've heard the term used, liquid biopsy. What is meant by that? And what are you looking for in someone's blood?
Yeah, no, that's a great question. So liquid biopsy is meant to be a comparison to a tissue biopsy. So traditionally, you have to have a tumor that is accessible surgically or by a percutaneous or through the skin type of needle biopsy. You need to get a piece of that tumor to be able to evaluate it. What we've learned is that tumors will shed some of their material, be it proteins or nucleic acids, into the bloodstream. And through a simple blood draw, because of technological advances, we're now able to detect tumor-specific material in the blood, hence the term liquid biopsy.
Interesting. So who is a candidate to have this test performed?
So for this particular test, the goal is to use it in conjunction with existing screening paradigms. So it doesn't replace a mammogram, low dose CT scan, pap smears, what is appropriate for age and gender. It is meant, again, to be used in conjunction with those tests. So it's really geared at the screening population and any individual who might be at risk for malignancy. And that could simply be by age. So anyone over the age of 50 undergoes screening. And then there are certain other high risk factors like smoking history, family history, some other considerations for who might be eligible.
Is it widely available?
So right now it is not FDA approved. You can imagine this test was developed in a short time span, only 5 years.
Wow.
And in order to establish this as a new screening paradigm officially, meaning guidelines have adopted it, the FDA has cleared it, insurers will cover it. This will take time because we have to demonstrate not only that we can do this, because we've now shown, we meaning the entire research world, that you can detect cancer-related material in the blood and facilitate cancer detection. We have to prove that acting on that, using that as a trigger for diagnosis of cancer, will in fact improve outcomes. And that could take years to do. So right now it is available as what's called a lab developed test. Blood can be drawn. So a test has to be ordered by a physician who understands what the test is and how to interpret the results. Prescriptions can be given to patients. They can go to selected labs, have the blood drawn, the test run at the company in their central laboratory, and then the result returned. It is an out-of-pocket cost, again, because insurance companies aren't covering it yet.
Interesting. Can you give some examples of the types of cancer that this test would be screening for?
So it can, in theory, detect for any cancer. In the development studies and the early validation studies, over 50 types of cancer were detected by this screening test. So it's based on blood and cancer signals. It does report on signal detected versus not, meaning there's something in the blood that's saying there might be cancer there. And I say might because it's not perfect, nothing is. But it also, in individuals who have a cancer signal detected result, will report a predicted origin, meaning cancer might be there and it looks like if it is there, it's coming from here, from which organ. And so that will help guide the subsequent workup for individuals.
Interesting. And does it detect for primary cancers versus secondary cancers? In other words, cancers that developed after a treatment. Is that correct for a secondary cancer?
Right. I think there are multiple terms, recurrences, et cetera. So certainly it's geared towards early cancer detection, finding a new cancer, hopefully at an earlier stage than when it might otherwise present symptomatically. Again, many cancers don't have screening paradigms. So most of the time you find it either just by accident because a scan was done for another reason, or because someone has symptoms and it led to a workup. So the hope is that we'll be able to detect, again, multiple cancers across the spectrum.
So Minetta, the test is drawing blood out of a vein, I assume, typically in someone's arm as when we go to the lab. Does the test tell the result of where the cancer is located in the body, or does it give you an indication and then the clinician goes hunting?
Right, so this particular test does provide a result or a predicted signal origin or where the cancer might be to help guide the workup, because there are multiple concerns about having a blood test like this, right?
Mhm.
Number one, you don't want to find every single cancer, meaning cancers that might not affect mortality, and that's the danger of overdiagnosis.
Oh,
The other concern is the possibility that will trigger with false positives multiple workups that aren't needed, right? And then along those lines is what you're getting to, which is, directing the workup. Because imagine you have someone who's healthy, gets their blood drawn, it says cancer signal detected, but they have no symptoms and their physical exam is totally fine. You're going to potentially go on a wild goose chase, right?
Mhm.
Looking for where that primary might be. So having a predicted signal origin may help tailor that workup so that a colonoscopy is performed or a CT scan is performed or some specific, physical exam. So that will hopefully help to streamline healthcare costs.
Because I can imagine it could also be very anxiety provoking for a patient just to know there's a cancer signal detected, but we don't know where it came from.
Exactly. Or that a cancer signal is detected, it might be coming from here. You had an extensive workup, but we couldn't find the cancer.
Oh, yes.
So an important component of all of the studies that have been and are being done, as well as anyone who is getting the test done, is going to be long-term follow-up, because it's possible that we'll find a signal. Cancer is not physically present yet, like we can't see it yet, but it will be soon. So we need to be following closely so that we're not missing it.
Minetta, you mentioned that at this point, this test would be used in conjunction with the screening tests that we already have in place. Can you foresee a future when cancer screening might look differently and we don't have to do colonoscopies or mammograms, which are, or other tests that are uncomfortable to people?
So I would, I guess, I hope so, but that's because I am completely immersed in the world of blood-based diagnostics and would hope that we can limit discomfort and do more and more from the blood. This, though, is a screening tool. So it is basically a trigger to do a workup with diagnostics to identify a diagnosis. So the hope would be, I think the reality would be, that not everybody needs a mammogram every year, right? Maybe we do the blood test every year, and then we do some form of breast imaging if there's something that triggers the need to do it. So maybe we're being smarter and more personalized about how we're screening our patients for the potential malignancy.
Well, that's absolutely fascinating. Good luck in your work. It's exciting.
It's a monumental effort across many disciplines, and I just get to be a part of it and feel very privileged to do so.
Any last words of wisdom you'd like to share with our listeners today?
To talk to their physicians about cancer screening. I think we are all sometimes afraid of cancer screening and what we might find. We still need to do our guidelines-based screening, and complying with that can be difficult because, as was brought up in the introduction, all of those cancer screening tests are done at different intervals, in different ways, in different centers, in different departments. So it can be cumbersome and costly, and hopefully using the blood as an adjunct to that will be helpful. But it's really a careful conversation about the potential risk that an individual might have, and they should have that conversation with their treating physicians.
What fascinating information. Thank you for being here today, Minetta.
Thank you for inviting me.
Our thanks to Mayo Clinic oncologist Dr. Minetta Liu for being here today to talk to us about exciting advancements in cancer research and in the detection of cancers. I hope that you learned something. I know that I did. We wish each of you a very wonderful day.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.